Today we will be discussing about rickets, and before discussing that we will be discussing about the metabolism of vitamin D, that is very important for the rickets. So as all of you know, we can synthesize the vitamin D into an active form in presence of sunlight UVB rays. Okay, so ultraviolet B rays directed on the skin, and we can synthesize the vitamin D3 in our body. We can also absorb the vitamin D3 from animal sources and vitamin D2 from plant sources. This is known as ergocalciferol. And this is known as cholecalciferol. This vitamin D3 goes into the liver, and inside liver 25 in the influence of 25 hydroxylase enzyme, the 25 hydroxylation is done, and the product that comes out is 25 hydroxy vitamin D3. This 25 hydroxy vitamin D3 goes into the kidneys, and under the influence of enzyme 1 alpha hydroxylase, one 25 dihydroxy vitamin D3 is produced, and this is the most active form of vitamin D. Okay, this vitamin D increases the calcium absorption from intestine, calcium and phosphorus absorption from intestines. Okay, and increases the bone mineralization, this also induces differentiation in immune cells, so increases the immunity of the body. And finally, tumors microenvironment, induces differentiation, inhibits proliferation, and inhibits angiogenesis. So all this is in tumor microenvironment: increased calcium and phosphate absorption in intestine, increased bone mineralization, and induces the differentiation in immune cells. Some genetic influence is also there over the metabolism of vitamin D, and we are going to see what's the genetic influence. Normally when we order a vitamin D label, so what we are ordering is 25 hydroxy vitamin D3, that is measured in the blood. Okay, and 125 dihydroxy vitamin D3, it is only 1%, only 0.1%, but it is the most potent of the vitamin D3s. So this is the best indicator of the vitamin D3 level inside the body, and this is the most potent form of the vitamin D3. Gene does is it decreases the FGF 23, and in turn FGF23 that inhibits phosphate reabsorption from PCT. This inhibition is decreased, so phosphate can be reabsorbed. But if this FEX gene is mutated, so this will not inhibit and FGF23, and FGF23 is, if not inhibited, will increase the inhibition of phosphate reabsorption, and the phosphate that should be reabsorbed will not be reabsorbed, and there will be phosphaturia and hypophosphatemia. Okay, one more thing is 125 dihydroxy vitamin D3, that is the active form of vitamin D3, upregulates FGF23, and in turn FGF23 inhibits its formation, inhibits vitamin D3 dihydroxy formation as a feedback mechanism if calcium is normal. So if calcium is normal and 125 hydroxy vitamin D3 is more, so it will upregulate the FGF23, and FGF23 sensing the calcium is normal, there is no requirement for 125 vitamin D3, will inhibit the formation of 125 vitamin D3. So if on reports we are having normal 25 hydroxy D3 but increased 125 dihydroxy vitamin D3, this is a severe dietary calcium deficiency, and treatment would be calcium. So now we will discuss about what is known as X-linked hypophosphatemic rickets. So what happens in this? There is FEX gene mutation. So we just discussed about this gene. What it does is decrease the FGF. So when this gene is mutated, there will be increased in FGF23, and because of which there is increased phosphaturia and decreased phosphate in the blood, that is hypophosphatemia. And despite hypophosphatemia, despite decrease in phosphate, the 125 dihydroxy vitamin D3 will be low. Why? Because FGF23 decreases the synthesis of vitamin D3. So and also due to deranged response of renal 1-alpha hydroxylase. Okay, So what are the clinical features? Firstly, mother may be affected. This is familial form, so mother may be affected in X-linked hypophosphatemic rickets. Secondly, a severe form of rickets will be there. Growth retardation, dental abnormalities, and symptoms of calcium deficiency, there is decreased calcium are absent. That is, no tetany would be there and no muscle weakness. Even though this is a very severe form of rickets and you would expect this to be severely deficient in calcium, but it's not. What are the lab values are? That there is a decreased phosphate, decreased 125 dihydroxy D3, normal 25 hydroxylase D3, serum calcium is normal, and increased urinary phosphate is increased. There is normal PTH as vitamin D3 and calcium levels are normal. Okay, and increase in alkaline phosphatase will be there. So what will be the treatment for this? Then treatment for this is phosphate supplementation should be given, 30 to 50 milligrams per kg, and vitamin D should be given. So what vitamin D analog will be used is alpha calcidiol, because alpha calcidiol is deficient. So what amount? 25 to 50 nanograms per kg per day will be given for treating this hypophosphatemic rickets. So the most important thing is this FAX gene. When FAX gene is not working and FGF23 is increased, just because this is increased, this will inhibit 125 hydroxylase and increase the phosphate urea, and hypophosphatemia will be there. Okay, and this will result in X-linked hypophosphatemia. Now we will discuss the autosomal dominant form of rickets, that is autosomal dominant hypophosphatemic rickets. This is the same as X-linked hypophosphatemic rickets, except for the change in the peptide cleavage site. That is that prevents the normal proteolysis of FGF23, leads to accumulation of this. So in this again FGF23 is increased, but because of defect in the peptide cleavage site, and in X-linked recessive it is because of the FAX gene was defective. So this only difference between the two is this. Third is autosomal recessive hypophosphatemic rickets. Okay, so all things are normal, except all things are same except for the protein, that is dentin matrix protein 1, that is DMP1 protein mutation. Normally this inhibits FGF23, but when this protein is mutated, it will no longer inhibit the FGF23 and increased FGF23 will be there. Again, this will cause hypophosphatemic rickets. Next is hereditary hypophosphatemic rickets. With hypercalciuria, that is autosomal recessive. There is a primary renal phosphate leak due to transporter defect. So there will be the leak. This will lead to phosphaturia and decreased phosphate. And also hypercalciuria. Lab values will be increased 125 dihydroxy vitamin D3. This will increase calcium absorption, decreased PTH, and leads to hypercalciuria. So because of decreased phosphate, active vitamin D3 is increased. This leads to increased calcium and decreased PTH. PTH will not let your phosphate reabsorption to decrease, and calcium reabsorption from kidney will also be decreased due to PTH and leads to hypercalciuria. Treatment is phosphate supplementation. So next we will be discussing about the dense disease, that is X-linked recessive hypercalciuria and nephrocalcinosis. Because increased amount of calcium is being excreted, that lead to nephrocalcinosis. What is the cause? Is because of loss of function, mutation in voltage gated chloride channels. CLCN5. So there is a loss of function mutation in this voltage gated chloride channels, and clinical features are there will be proteinuria, beta 2 microglobinuria, phosphaturia, hypercalciuria, nephrocalcinosis, and nephrolithiasis also. Sometimes Fanconi syndrome can also present as rickets. All of you must be knowing about the Fanconi syndrome. Presentation is rickets, failure to thrive, polyuria, polydipsia, etc. Seventh in the list is vitamin D dependent rickets, and this is two types. type 1 and type 2. Okay, so type 1 is this is also known as pseudo vitamin D deficiency rickets, because there is no deficiency of vitamin D, but due to decreased 1 alpha hydroxylase activity due to loss of function mutation of CYP27B1. This leads to decreased calcium, normal to decreased phosphate, increased ALP. The most important thing that I told you is 25 hydroxy vitamin D3 is normal. Okay, so in case of vitamin D dependent rickets type 1, this will be the measured vitamin D, and this comes to be normal. So there is pseudo vitamin D deficiency. Although the vitamin D that is we are measuring is normal, still this is a type of vitamin D deficiency. So what will be the clinical features over here? In this, early onset hypotonia will be there, growth failure, motor retardation, seizures due to hypocalcemia. Plus signs of hypocalcemia such as Rorschach sign will be present, delayed dentition, and enamel hypoplasia. So this resembles nutritional rickets, but does not get corrected by vitamin D supplementation. So treatment will be physiological dose of alpha calcidiol and plus calcium need to be given. So this is type 1 vitamin D deficiency. What is type 2 vitamin D dependent rickets? In case of type 2 vitamin D dependent rickets, there is end organ resistance of vitamin D. End organ resistance to vitamin D means to say there will be early onset rickets, alopecia totalis, ectodermal defects will be present like oligodontia, milia, epidermal cysts. LAB is decreased calcium, secondary hyperparathyroidism increased, 25 hydroxy D3, and absent response to vitamin D analogs. Treatment is very high dose vitamin D plus IV large amount calcium infusion. So that's all about the vitamin D metabolism that we need to understand and learn. We have not discussed the features of rickets, as I think that you all know what are the features of rickets, and if you want me to make a video for the same, I will make a video for the same, but these are the most important points that you need to understand for metabolism of rickets.